Hello, my name is Amy Updike, and I am a second-year doctoral student in the College of Nursing. Today, for Statistics 507, I'll be doing my presentation on breast cancer surveillance regarding reoccurrence in patients, particularly after a mastectomy. Some background: cancer is a disease in which cells of the body grow out of control. Breast cancer is actually the most common cancer in women in the United States besides skin cancer, and it's the second leading cause of cancer deaths among women and overall in Hispanic women, causes of death. Each year, approximately 237,000 cases in the U.S. are diagnosed in women and 2,100 in men. 41,000 women and 450 men in the U.S. die each year from breast cancer, and approximately 10 to 15% of patients with stage 1 and 2 invasive breast cancer will develop a clinically isolated reoccurrence. This is according to a study that I will be referencing quite frequently throughout my presentation, presented by Freeman and Fobel in 2000. Standard management of recurrence following breast cancer conserving surgery and radiation is a salvage mastectomy, while local excision and radiation are optimal treatments of the chest wall reoccurrence following an initial mastectomy. Some of the risk factors: it goes up with age. Usually, women are diagnosed around the age of 61, where the average for men is between 60 and 70. Race is highest among white women. However, it's closely followed by Black, Hispanic, Asian, Pacific Islander, and American Indian and Alaskan Natives. Also, geographic location: there's a higher incidence I found in Connecticut, DC, and Delaware, and primarily the Northeast states, whereas the lower cancer incidents occur in Texas, New Mexico, and Arizona, and usually the Southwest states. So for this project, I came up with 3 different surveillance questions. One is, who are at higher risk for getting breast cancer recurrence? Is it related to the age or race? When is a person likely to have a reoccurrence? Is it less than 5 years, 5 to 10 years, or greater than 10 years after a mastectomy? And where in the U.S. is the highest breast cancer rates? Is it north, south, east, or west region? The purpose of these surveillance questions is to identify those that would be at a higher risk for breast cancer recurrence, identify a potential link with age, race, or geographical location, and to identify individuals that should be screened more frequently based on how long after their procedure they have follow-ups, such as the 6-month to a year mark. Data sources come from the Center for Disease Control, the Cancer Network, Journal of Oncology, and a lot of these will be referenced in my resource slide at the end. Some of the collection systems is the National Breast Cancer Registry, also literature reviews and national case studies. I will speak about the gaps a little later on in the presentation, but these are the basic data sources in which I was able to get information based out of, for example, the National Cancer Research Registry is where anytime that there is a diagnosed case of cancer, the doctor is required to put it into the national registry. So this one in particular was based on the cancer registry. So analysis: based on a study by Freeman and Fobel, which I had alluded to earlier, analyzed databases, registries, and literature reviews regarding breast cancer recurrence following radiation and mastectomies of stage 1 to stage 3A breast cancers in the United States. It overall helped with the furthering of research, follow-up, and screenings following radiation and surgery, and other studies have also been evaluated, identifying recurrence and survival rates that identify the importance of surveillance measures to prevent progression and reoccurrence. So the results is my primary focus for this is the approximately 10 to 20% of patients with stage 1 and 2 invasive breast cancer will develop an ipsilateral breast cancer tumor recurrence, or IBTR, within 10 years of breast cancer conserving surgery and radiation. Also, 10 to 20% of stage 1 to 3A invasive breast cancer will experience chest wall failure with or without simultaneous regional failure within 10 years of undergoing a mastectomy. So some of the factors associated with increased recurrence is young age. They were finding 35 to 40 years or less, which is interesting given the fact that most diagnoses breast cancer is above the age of 60. Tumor size of greater than or equal to 5 centimeters have approximately a 25% higher risk of recurrence. Genetic factors such as the BRCA1 and BRCA2 mutation, which are genetic tests that can actually be done to predict the likelihood of a patient developing breast cancer down the road. Lymphovascular invasion and marginal status, if there was a deep invasion that was needed to excise the tumor itself. Median time for reoccurrence, they found, was between 2 to 3 years, but noted delays in patients taking tamoxifen. And this is something that I would like to really key in on, given the fact that 2 to 3 years is the beginning of your continued surveillance. So, which is why they say after 5 years, it's less likely that you'll develop it, and so on and so forth. So your screening, it actually decreases. Also, the fact that tamoxifen is an up-and-coming medication. They've used it for quite a while, but they're seeing more and more positive effects, long-term effects by using it. And it's something to keep in mind with medical advances in general, is that a lot of this information 5 to 10 years down the road can actually change based on how far we've come with medical advancements. Some of the survival rates, this is based on the Metastatic Breast Cancer Network in general. 89% at 5 years after diagnosis have a tendency of surviving longer, 83 after 10 years, and 78 after 15 years. This is not the reoccurrence rate, this is just the long-term survival rate. And surveillance is crucial in prevention of reoccurrence or the progression of reoccurrence. Some of the limitations based on this research that I've done shows that cancer registries don't actually track metastatic reoccurrences, and there's massive gaps identified in how people with metastatic breast cancer are counted. And this is something that the Metastatic Breast Cancer Network is really striving to develop and further push, that the registries are more precise with their numbering and their counting, which will also lead into furthering surveillance and keeping track of these patients after their surgeries 5, 10, 15 years down the road. So some of the conclusions based off of the surveillance questions, which is what my main focus was for this presentation, was that age does play a factor. Race can play a factor. So basically, as we discussed, the age 35 to 40 shows a higher increase of reoccurrence. And it is important to keep in mind that the risk factors are 60 and above, put you at a much higher risk. Race can play the factor in terms of white females being at a higher risk, immediately followed by Blacks and Hispanics. And to keep in mind, again, that Hispanics this is their leading cause of death in cancer deaths for females. It is likely to reoccur within the first 10 years post-mastectomy, more likely 5 years post-mastectomy. So the surveillance and the continued diagnostic tests and follow-up care is imperative, especially in this window, to avoid progression or new occurring cancer. Geographical location can put one at a higher risk based on resources and environmental factors, and this is based off of any type of public health research studies that you do, such as low-income housing, the environmental factors of carcinogens in the air, any type of chemicals that the patients may be exposed to, smoking, and that's smoking within the household, smoking in different geographical locations throughout the United States. It does show, as earlier, that at a higher risk in the Northeast and then at a lower risk in the Southwest, but that doesn't mean that if you live in those particular areas that you're at, that you will never get breast cancer, or you will definitely get breast cancer. So some of the next steps that we need to utilize this information is that more research is needed in long-term follow-up with post-mastectomy patients. As medical breakthroughs happen with breast cancer research, it should be noted that reoccurrence may decrease based on new treatments, and we must work to improve the gaps of the registries to ensure proper data is being collected and that proper surveillance measures are being in place based on long-term studies and follow-up care. These are my references. As you can see, the Center for Disease Control is a big part of basic statistics and general information for breast cancer. And then the Friedman and Fobel study out of the Journal of Oncology was the primary focus for the majority of the information given in this presentation. And then Metastatic Breast Cancer Network that gives a lot of insight to the reoccurrence and different factors that are put a patient at a higher risk for reoccurrence. That concludes my presentation for today. I hope you enjoyed it, and I look forward to your comments as well as reading reading the rest of yours. Sorry.